Strategic Caring Solutions. This is Erin. How may I help you?
Hi, Aaron. Tim Card.
Hi, Tim. Good. How are you? Oh my God. Okay. That's okay.
Can people hear us?
Yes.
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 That's pretty good.
There you go.
Thank you.
Thank you. Sorry.
Good morning. Thank you for your patience while the departmental team figures out their new tech stack. It's all good. Kristen, do you need a minute?
Just this one. Yeah, you can go.
Maybe members could log into the chat.
That would be delightful. Good idea, Kelly. Could members just make yourself known in the chat so we can make sure we have a quorum? Seems like the preference is for most people not to have cameras on, so I have not memorized the initials of all the official members.
This is Ellen. I can't get onto the chat, but I just wanted to let you know I'm here for the GCD.
Thank you, Ellen.
Good morning.
Brooke Belanger, Carolyn Virtue is on. She's an alternate.
Can you see the chat on your computer?
I'm actually logged on to here.
Okay.
It won't allow me, I can't log
In the
on.
chat, we've got Lisa Adams, Marissa Berg, Carolyn Virtue, and Jake Berry.
You. I'm Joe.
Jay.
And Joe, yeah.
Oh, Cara,
Three, yeah.
Cara's one, too. Karen Rosenberg.
I love that.
Mike Auerbach's here as well. I logged into the chat.
Lisa
Hi,
Adams,
Mike, thank you.
Okay.
Marissa Berg,
We're good.
Mike Alberg.
Okay.
Michael Miller, I think is the only one. Nancy Juke is an alternate.
Good morning. You guys do have a quorum.
Oh, thank you.
Thanks, you have a
Thank
better vantage point. Thank you for the confirmation, we appreciate it. So just for those of you, so it's new tech here in 468, we're all feeling our way. Here in the room is Kelly and myself and Joan Fitzgerald for members, and of course we have Kristen and Henry and David for the department. I know last month we had some challenges, with people like raising their hands and unmuting, and so we just want to make sure that if we struggle again, I have a hard time seeing the screen. I'm hoping by sitting in this direction it'll be easier. I've got Kelly over there closer, so hopefully we won't miss any questions. If your hand is up and we don't recognize you, please drop your question in the chat and Kristen will prod us to make sure that we get some sunlight on your question. But if we could just have a little space and grace while we figure this out, we're doing our best. And anybody who wants to join us in person is always. All right. Let's. Okay.
Yes.
So does anybody have comments or questions about the minutes? I think we have. Yeah, so we have July and August that we need to hopefully vote. July should be all set after the exchanges that we had before. So why don't we start with July and see if we can take a motion?
I motion that we accept July minutes.
Second.
Thanks, Joe. Thank you. Any discussion? All in favor?
Aye.
Aye.
Excellent. All right, moving on to the August minutes. We have go ahead.
Hi, this is Ellen. I just wanted to let you know it takes so long to unmute that by the time I get there, the voting's already happened. So just assume I'm voting for things unless I speak up and say I'm not.
Noted. Thanks, Ellen.
Okay, thanks. All right, thanks.
All right, any comments before we ask for a motion on the August minutes? Hearing none, can we have a motion to approve the August minutes?
I motion we approve the August minutes.
Thank you, Joan. Do we have a second?
Second.
Thank you. Any discussion? All in favor, say aye.
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 Super, thank you. So we just want to make sure that we check in with everybody. Are there agenda items that you would like to see added for future meetings? These would be brand new, not things that we're currently tracking or are already in the queue. Anything in the chat? Kristen, I just can't.
I'm taking notes.
Sorry.
Let me look. Yeah, to chat one second.
I apologize.
Check.
Can you hear me? Oh, someone has a hand.
That sounds like Lisa DiMartino. Lisa, go ahead.
First question, and I don't know, maybe Henry, you could answer it now, or we can schedule another time. Reading rate increase, and I guess it was pretty historic. And I was wondering if there was any way we could hear about this Medicaid rate increase, what it is, how it's uniform, the rate increase, or is it different for different systems? How do we compare to other states in New England? Will this past increase make a difference in the workforce challenge so many of us are experiencing and still experiencing? So thank you.
So my suggestion on that is we had put together a report last October, I think it was, for the fiscal committee, that we could distribute that report and then have a discussion of that next meeting. I can say this is that we had a number of inquiries from people about that rate increase with respect to the two parts. I'll give this piece of information, which I can give off the top of my head, that might be helpful and maybe avoid some of the confusion, but I think we can spend more time in another meeting. So when the legislature passed an increase for 2024 and 2025, so some people mistook that as being two increases, when in fact what it was, the first increase covered a 6-month period. So that was there was an appropriation for the 6-month period. Then the legislature appropriated to continue that 6-month rate for the balance of all of 2025. They appropriated enough money to cover the 2025. So there's not a second increase. It's that there's an increase for 24 for 6 months, and then there was an appropriation for 25 to continue that increase for 12 months. But be happy to share the letter and then have a deeper discussion at a subsequent meeting.
So appropriation for 6 months for one fiscal year, appropriation for 12 months for the subsequent fiscal year.
Correct. Basically, if you think about it this way, the first increase was a real increase. The second one was to sustain that increase.
So my understanding is correct. So this isn't a permanent increase, it's just a temporary money to put into the system to help it. Am I hearing that correctly?
No, I think that, each legislature, each budget session, the whole thing is up for, but I think that, I think it's, politically viewed as a permanent increase. And then whether the 26-27 budget process, which we're just in the agency phase, that it's confidential phase at this point. It then goes to the House and the Senate and so forth. So, and then we're going to have a change in governor, so we'll in effect have another phase. So I think in terms of the way we view it, I think is that it's built in. But again, the legislature has cut the budget in the past. So there's every 2 years we're subject to a new budget process.
But it showed up because it was an amended budget.
Yes.
So it was an amended 24-25 budget that we would expect to be sustained, but every year when the budget comes out, anything can happen.
Yes. I would not expect that they would go backwards, but whoever gets elected and whatever advocacy, the budget it starts really from ground zero every number of years.
Workforce challenges, and we know the MEC when it comes to the and I will speak to the DD system. Challenges are huge, and it is hard to find workforce individuals to work for under 22. You compare and I work on the future. It's so, and we need permanency to make the system strong. Going back and forth or not, forecasting or looking for the future makes it hard. It makes it hard for systems to plan. It makes it hard for families and individuals to think about their loved one's future. So anyway, doing a presentation on the Medicaid rates would be wonderful. I am not going to be able to attend the next MCAC meeting, so if we could hold off till November's meeting, that would be great. But I may call you, Henry, on this. Thank you.
You're welcome. Happy to help.
Okay, any other suggestions for future agenda items?
I guess that one matter with respect to, we received an email from Gina Balkus, who's going to be retiring, and I think Gina had proposed that the replacement executive director, I believe, to take the role. That position is, in our bylaws, is not one of the stated organizations, so I think it needs to go through the membership committee. Seems to make sense to, Gina represents an important part of the healthcare delivery system, but I think the formality of our bylaws have us go through the membership committee, and if Gina's on, she could speak up about what her transition is, but it's, I think, pretty soon. Not hearing Gina, we'll connect through you, Lisa Britt, to get the membership committee situated to take this up for.
On it. Okay. Shall we turn it over to Dave for enrollment and eligibility?
Yeah. So I'm just gonna share my screen. So this is the monthly enrollment and eligibility discussion. So the first slide is just an updated slide of our ex parte rate. So you can see for September it was 85%, and October similarly high with 84%. And this is about 5 to 10% higher than we've seen it over the prior months, where we're trending around 75 to 79%. So ex parte rate continues to remain high, which is helpful for throughput on application processing. Next up is a slide. It's a point in time snapshot of enrollment trends, and you can see over here to the left is the beginning of the pandemic, and then the current is over here. We're running at 181,000 right now, which is roughly 1,000 less than the month prior. So we have a couple other slides digging into this a bit more. So this looks at from the first of the month, starting November, moving forward, what the enrollment trends were in various eligibility categories. So in the brown, you can see we've got the adult expansion and low-income children, which sort of continues on this upward trend, despite a little drop here. But much of this upward trend, which starts around here, that's January, and kids now have the 12 months continuous enrollment. And this is a similar look at the last slide, but really breaking each one out. And so this looks at the first of the month, starting in November, what the total enrollment was in each group. And then it goes forward December, January, up through September 1st. And this is the dashboard for the adult population for their redeterminations that occurred in August. So you can see 5,900 completed redeterminations, 629 closed. The large majority of those redeterminations that completed readies were passively or ex parte renewed, which tracks with our high ex parte rate.
I guess the ex parte rate is among the highest in the country.
Yep.
And significantly above the national average.
Yeah, I think the national average is around 45 to 50%. And we've always been trending higher in the ex parte rate, top 5 in the nation. But I think the past couple of months we have been.
Other states have started to, and there's also a factor of when you started. So generally the trend is the longer you've been into it, the better you get at ex parte. But we're basically through all the redeterminations that were related to the PHE. So there's some flexibilities that run through December 25 that help this rate, and we'll see what happens federally with that over time.
We're seeing similar numbers with this is just the children dashboard for August. So there were 5,600 individuals or kids due for a redetermination. 4,600 completed the readie, 683 closed, but the majority of those were passively renewed, about 4,000.
I think the thing that we want to focus on, I think in terms of the change in enrollment, early on in the pandemic, like May of last year, that, parents not understanding that they were not eligible, that their kids still could be eligible. We're planning additional outreach in that space, but any way you see can contribute as stakeholders to getting the word out on kids. We want to make sure no kids are falling through the cracks. We gonna be running some internal reports to look at this issue further and do more outreach on it, but,
And we're planning to engage the MCOs on some of that outreach as well too. So we can hopefully have multiple touch points.
the other thing I would say is the snapshot that we look at the beginning of the month. You remember September began with like a holiday, so the numbers, fluctuate week to week, so it's down a little bit from September from the trend, but, not tremendously so. But it'll be interesting to see it next month, whether it comes up a little bit, result of just the timing of the month.
Mhm.
And we have the reconsideration period too completed because vacation or the holiday, as long as they get it completed within the reconsideration period, they'll reopen back to the September 1st date.
Can you just speak to me about the reconsideration period? Who does it apply to and what's the duration or the window?
It's 90 days for reconsideration. I think that is for all.
Yep.
With no distinction.
Yeah, it applies to everyone who's going through a renewal.
So what you may be thinking of is during the PHE, we gave additional time before we acted on something, and that we did on waiver populations.
Okay.
It's the dashboard slide for the waiver population financial redeterminations that happened in August. There's 605 due for redetermination. There are only 2 closures, 563 completed the redetermination, and there were 40 pending at the end of the month. And this is a subset for the CFI population from that waiver slide. 2 closures, 203 completed reads, 19 pending. And this is the nursing facility dashboard for August. 264 due for redetermination, 1 closure, and 194 completed. It looks like the 1 closure was due to income. And this is just a look at our CMS reporting for the month of August that we submit. Overall, you can see the retained number is 88.9%, which is expected, with the high ex parte rate as well. And then we have the closures and the closure reasons, which failure to read is the highest, followed by income.
The national average, I think, on failed to read is over 60%, but with such a high ex parte rate, that's just the people who weren't renewed otherwise. But still, that the outreach there, that's what still says that for whatever reason, there's a large percentage of people who aren't going to be eligible who don't take an action. But, 85, 84, 83%, 80% are renewing automatically without having to do.
Yeah, and if someone doesn't ex parte renew, say they don't pass the income test when the electronic system looks, and so they have to complete a redetermination manually, some of those people may not, if they got a new job and they know they're not going to qualify based off of income, and so they won't go through the process and they'll fall into the failed to read bucket because they don't complete the application.
I have had a couple of challenges in my organization, which other people may share out here, for people who are in the RED process where we have had a release on file, and now what we're hearing from BFA is that there is no such thing as a release. You're either an auth rep or you're not the auth rep. And it is posing challenges for us when we're not the auth rep, but we think we have a release on file, Form 11, I think, which is now, we're being told it's not a release. And so we are running into challenges doing case management and advocating for folks. I have been in touch with Dawn I think there are some policy changes and things on forms that are in play. So if we could just get a lens on that, and
Yeah, we
maybe
have a-
that is a future agenda item.
We have a meeting today actually on that.
Okay, great.
They're trying to make the policy clearer to the individuals who are the workers, and there's still some work we need to do on that policy. We've been working on it for a while, but hopefully we're getting to the end point here. But that is sort of like the recognition of the relationship between the provider and the individual, that our policy at a global level is that they should be able to share a certain level of minimally necessary information to help you. But it's been something we've been working on, and hopefully we'll button down before we meet next week, and we can share some more information.
Yeah, and in partnership, whatever the policy is, like if I'll just put this out, if the policy is you must be authorized, I know it isn't, but if it was, then at least we can communicate to people and say, if you want us to advocate for you, then this is what we would need to do. So when it's clearer, yeah, just
So
pass
I
it
think
along.
our policy, so here's, I think, sort of a scenario. Someone calls up on the phone and says, such and such provider, this is a patient of mine, without a call, just the certainty to protect confidentiality is how they can verify that there's a treatment relationship, so therefore they can share the information. That's kind of the nuance that we're trying to work through.
Thank you.
And the last slide is an update on the MEA reporting for July, for MEAs that were due in July. What's new here is you can see there's, in both the individuals that continue to remain open in Medicaid or closed in Medicaid, there were no failure to provide MEA documentation. There were a couple that didn't meet the level of care. But I think this is, when we look back at June, there was a really low number of failure to provide MEA documentation, and now it's 0. And we don't have the obvious data yet, but it's good to see that number continuing to trend down.
So the other piece that's coming online is the New Heights system changes, or as you would think about it, as New Hampshire Easy, in terms of access to being able to see what's going on, and that might be actually a good topic to cover at a subsequent meeting too.
Right.
That's going, I think, live this week.
Yeah, I think it may have gone live on Friday evening, so effectively today.
So that would maybe help you not even having to call the workers, but to be able to look it up yourself.
Yeah.
That's it.
Okay, awesome, Dave, thank you. Any questions for Dave before we move on?
Thank you for the update.
All right, should we, is Jordan with us to be able to do the Medicaid to Schools RFI?
Yes, I'm online.
Okay.
So I'm gonna start with just sharing a quick slide deck for sort of some context for everyone. Sorry, I think I'm echoing in the room. So just to go over some cost-based funding concepts before we get into the RFP and the RFI. Currently, New Hampshire receives federal match for Medicaid to schools through a model called in-kind, where schools will bill directly to the state through MMIS, and they will be reimbursed at 50% of the fee schedule. The other, the 50% that they're not reimbursed is the federal, the state portion. They are reimbursed the federal portion. We are no longer able to keep this methodology after June of 2026. So New Hampshire is looking at moving to a cost-based methodology. So I'm going to review a couple kind of concepts around cost-based methodology. But as we go into that, I want to point out that while the transition, I think, will be, complex for schools to adapt to and a lot of work on everyone's part, at the end of the day, we anticipate that there will be increased funding to schools as a result of the change. We'll be able to have schools claim for administrative costs as well. And the increased reimbursement goes back to the LEAs individually, and LEAs can decide, how they'll use that increased reimbursement. So this is just an example of how schools currently, use their Medicaid funding, how they put that back into either medical support or other services for schools. For example, 70% of districts are using funding to support salaries of health professionals, expand health-related services, outreach and coordination. So those are just some examples. So just an overview of cost-based methodology. As I said, New Hampshire's current reimbursement model is just a kind of simple fee-for-service billing. We pay 50% of the fee schedule for each service provided to each child. The claims are submitted to Medicaid, and the reimbursement is sent back to the school. Under the cost-based funding methodology, I think the state anticipates that the billing will still continue the same to act as an interim payment to the schools, but at the end of the year, there will be a cost settlement for all of the costs incurred by the schools, which we anticipate will exceed, the reimbursement that they're receiving currently under our fee-for-service methodology. It involves a detailed cost allocation and reporting methodology based on federal cost reporting parameters. So we'll get into some of the process and documents a little bit more. Cost-based funding is a reimbursement method that contains a cost report that captures the actual cost of providing the covered health services as reported by the providers, and a comparison of the costs to reimbursement received through the interim payments for a defined period. So again, the schools will still be receiving payments, likely just through the same kind of billing model that they are right now, but it will be reconciled at the end of the year, and we anticipate that additional payments will be made to most schools at the end of the year. It ensures the providers are compensated for the full cost of the program, while also ensuring that Medicaid isn't overpaying for services. And it is currently the most common reimbursement method for school-based services across the country.
Jordan,
Again,
excuse me.
Yep.
Excuse me, Jordan. What's on the link on your prior slide? You don't have to go to it. I'm just curious what it is.
I would have to pull that up to verify for you, which I can do at the end. Does that sound good?
Thank you.
So again, elements of cost-based funding and reimbursement include an interim payment methodology, a cost identification process that identifies direct and indirect costs. So schools will have to create cost pools, which is basically just a way to break down different direct costs, administrative costs, and then a Medicaid enrollment rate. So that's just the percent of students in the schools that are Medicaid enrolled. Schools will have to participate in what's called a random moment time study. That's to kind of verify, at any random moment, what exactly staff are spending time, what activities staff are spending time on. They'll have to submit a cost certification statement, and then we'll go through a detailed cost reconciliation and settlement process. We will provide, obviously, detailed cost report instructions for providers, and I'll get more into that as well. So this is just an example of the how this is all calculated. So we're talking about direct medical costs directly tied to Medicaid, right? Medicaid enrolled students, total transportation related costs for Medicaid enrolled students, total administrative claiming costs, and then, we're taking our 50% FMAP rate. Schools are eligible for that 50% federal reimbursement for all of those costs. And then we'd be subtracting, right, any interim payments that they've already received throughout the year to do the cost settlement, which could potentially be, a positive or a negative amount. But again, with this methodology and with any interim payment methodology which we developed, the goal would be that payment at the end of the year would be positive. So the reason that I give this context is to let you know that we are developing an RF. Oh, sorry, go ahead. Oh, maybe that was just me echoing. Someone have a.
Keep going.
Keep going, Jen.
Okay, sorry. So we are putting out an RFP for a vendor to support this work and to work very closely with the LEAs so they can understand these concepts, understand how to do a cost report, how to participate in random moment time studies, and there'll be technology associated with some of these tasks as well. We're looking to get that RFP posted maybe by the end of the month, but prior to that, hopefully this week, we are looking to post an RFI, which will obviously kind of detail the scope of what we're looking for from this vendor. We have some questions both for potential respondents and for the stakeholders, so the LEAs and other stakeholders to provide us input before we finalize that RFP to make sure that we're asking the right questions, getting everything we need from the vendor when we do finally post that RFP. So once we do have the RFI posted, I can definitely send that around to the MCAC group, and obviously other stakeholders. The schools will get a message about it. But we wanted to bring it here to you all first. And Henry, I don't know if you have anything to add.
Yeah, I think we're also intending to do some sort of public forum on the RFI, right?
Right. Yes. And that will be, I think, probably next week and the week after. We'll be looking at setting up, one in person and a couple virtual sessions based on kind of like the school calendar to be able to capture as many school stakeholders as possible.
I guess, just to emphasize the transition here is not one that we have a choice on. The fact that we don't, we did apply for a grant which we received. It's going to be worth about $2.75 million to help the department and the schools make the transition. In the end, if you think about it, most Medicaid rates aren't set at full cost. And so there, in many states, has been a substantial gain when converting to this based on recognition of cost. Also, today, the rate does not reflect the indirect costs of like the people who may be scheduling appointments in the school administration. So the random motion time studies are intended to be able to capture some of those expenses back. And we talked to other states that are doing this and doing it in a very positive way. But New Hampshire's had a lot of tiny local education administrative units. I think that's LEA stands for. And so I think that some of the challenges of adopting this are based on how many people within the school administration they have to work on these issues. So we want to make sure that we engage with the stakeholder community to make sure we have what they need to make that transition. We're trying to provide at least a year's worth of lead time between bringing the consultant on board and actually starting the process of this. But I think net, it should be, in the long run, allow for more funding for communities to make decisions to invest in their schools as they see fit.
Do we have people present here from the education community?
not as a representative on
Yeah,
MCA's.
but even attending. I mean, my concern, of course, is that, people hear the word cost before. I hear you, by the way. And that it can be advantageous, probably will be advantageous. But people hear the word cost report and they panic. And so my concern is how does that downstream impact to kids in any LEA? And I know we're doing our best to get ahead of it. How can we keep our eye on that? Are we, how can we, as an MAC, support the department?
So the New Hampshire Charitable Foundation has stepped up to provide over the last number of years. In 2019, there started to be some significant transitions to in the Medicaid to Schools program. JSI, which is a consulting firm, I forget. John Snow Institute has had a last, I think, several years, a couple of consultants that are outreaching to schools. They also funded a group called the Healthy Students Promising Future, which is a national organization that the department and educational DOE has participated in, along with certain school districts. The Charitable Foundation the intent was that would be short-term funding, so JSI is evolving their role a little bit over the next couple of years. So I think there is a forum that the Commissioner of Education and I have spoken to the school administrative, the CFO kind of groups to let them know what's coming, and we do have a lot of work, and a lot of school districts don't have many people that are knowledgeable, and their turnover can change the whole thing. What we're trying to do, I think, is to leverage off of the billing process that already works, so that they'll be able to bill, continue to have a cash flow as they do today. The upside is at the end, there potentially could be, if they complete the reporting, there'll be an upside to that. But we wouldn't be able to maintain a claim that was based on just in kind.
Please let us know how we can support children and families and support through the MAC and maybe even through CBHA. We work closely with schools. If there's communication or anything that we can do to help in that way to maintain engagement, let us know.
Yeah, one of the big opportunities here is for schools to do more in their schools, and mental health is one of the areas that, I think there's an opportunity to take some of the additional funding to put it towards, or other areas. All those decisions get made at an individual school district level.
And I see Karen Rosenberg put a question in the chat about whether or not we've reached out to the New Hampshire Association of Special Education Administrators, and Jordan did respond, but we've given them a similar presentation, and we plan to meet with them quarterly too, so it's another touch point. And that I can see.
Thank you.
Jordan, are you all set?
Yeah, as long as there's no other questions.
Jordan, what was the link that you were not able to?
Oh, it was a Manat presentation.
Okay,
Yeah.
thank you.
So we'll distribute those slide deck. Manat gave an overview of this.
Great, thank you.
Okay. Let's move on to the department updates. I see Dr. Finney has joined us right on time. Thank you.
Oh, I've been listening in. Good morning, everyone. So first, I'd like to give you the update for adult dental, and then you're going to see me pop back up when Henry gets to the 1115 waiver, because I do have a slide deck to share with you regarding that. So in terms of the adult dental, we continue to slowly grow the provider network. We do have a number of providers in the pipeline right now, and those should be up in the system shortly. Our claim counts continue to rise every month, and as of the beginning of September, We are just slightly below 16,000 unique members being served since the implementation. So again, all these numbers are trending in the right direction and remain consistent. We have a very robust schedule for the next month and a half. The mobile services are booked out until at least October 20th. And one of the exciting updates that I have to share with you is that as of in the next week or two, additional dental hygiene services will be provided in the mobile events. This is in response to increased demand for that, which is a very good sign that our program is working the way we intended it to. We knew that we needed to help our adults get back into consistent dental care. And this shows that while, they may have had to go through some restorative care over the last year or so, now they're moving into that prevention portion of things. And so we're really happy. What this means is that, currently there have been 10 to 12 members booked and treated at each event. That will now go up to potentially 25 members being served at each event, which is a significant increase. So we're very, very happy about that. In terms of going back just for a second to the provider enrollment, I do want to note that there are continuing efforts to recruit dentists. And to that end, there have been over 200 in-person visits by recruiters with dentists, and 109 of those have been with non-participating providers to really try to encourage that growth. And then the last thing that I wanted to talk about, last month, Kelly Cappuccino asked for a description of how it is we plan the mobile services. And so I think the key to this is that we do have a quarterly planning meeting, which includes Northeast Delta, DentaQuest, Solvair, and DHHS. And we all come together to share the feedback that we have all received in our capacities. We look at what were the visits that we had in the past and where do we need to go for repeat locations. And then we really look at what kind of member calls came in to DentaQuest or Northeast Delta or Solvair, and even DHHS. We do sometimes hear from members here. We also get requests from community members and oral health advocates or legislators, and quite often they have a very specific location in mind. We do have to look at each location very carefully because we want to make sure that we're going to have a significant impact, as well as just space demands, because this isn't like a minivan that shows up to provide services. There is a very large truck involved. And then, of course, what's probably most important is just analysis of our Medicaid data. So we know where our members live and we know where our providers are. And so we overlay those maps to see which areas of the state are lacking the coverage that we need. So there's no magical algorithm that we use for this. It really is a conversation and discussion about, what we're hearing from the community and from our members, and really trying to make sure that we're answering that need. So I don't know if anyone has questions. I'm happy to answer them.
Hi, this is Ellen from the Governor's Commission on Disability. I have a quick question. I was wondering if the consistent reason for dentists not wanting to sign up with the program is still the problem of reimbursement costs.
I think that we're always going to hear that. I have to say that we've all done a very good job of looking at the fee schedule over the course of the time since we implemented the program. There have been multiple increases to specific codes that seem to be an issue. We're always looking at that. There's also a provider group that meets with DentaQuest on a quarterly basis. And that's, one of the topics that comes up. And that can drive, what we look at for, making changes to the fee schedule. I think that that's always going to be an issue, and we're always willing to look at, where we can make increases. But I still think that administrative burden is another piece of it. And we're also, really trying to see how we can streamline enrollment and, the paperwork behind all of this.
Yeah. That's great. I think you guys have done an amazing job. I've heard a lot of positive feedback, and some of the really reluctant providers that I had spoken with previously are now enrolled. And I'm just wondering if the pushback was still consistent. But thank you so much for all you've done on behalf of so many.
Thank you very much.
Are there other questions for Dr. Finney? Joan?
Yes, Dr. Finney, as the program reaches out to more preventive services, how are the dental hygienist providers being tracked for delivering those services?
The only way that we're tracking that is through, claims information. I don't know exactly what it is here. What specifically are you looking to be tracked?
Well, the services that they provide under their NPI number, so that you
there are only three it's either 3 or 4 hygienists who practice in Maine that are enrolled in this program, because in Maine they can be independent practitioners, and basically what we would use to see what services they're providing is the claims information.
So really what we need to do is mirror Maine and have independent practitioners.
That's a joke. We've talked about this many times. That's, certainly something that the Board of Dental Examiners can look at.
I just came from their meeting, so.
Yeah, I mean, that's not something that I can change.
I did present a structural change to their rules package and address the structure of the regulatory board to regulate, for dental hygienists to regulate their own practice and dentists to regulate their own practice. So yes, I think there are things that need to be enhanced, but I just see that if you could expand upon your provider network and really have an expansion of that preventive discipline and then know your numbers there, that would be a good thing for this program.
Well, we do have the ability to do that, and there are hygienists that are working, in this program under the providers, that are actually, directly enrolled. So I think that the structure is already there in New Hampshire. If we had the providers and the hygienists, working in different areas, it could be covered. I understand that, you would like to see dental hygienists reimbursed directly, but that is not something that we can do right now in the state as things stand. And so we have to work with the system the way it is to try to provide the services, that way.
It's a dentist-dominated system, by the way.
I mean, that, to me, the change would have to, if you're not able to convince on an interaction basis, then the other option, I think, is to try to get some legislative relief on that. I don't know whether the association that you're with has tried that route previously.
Well, it is it all becomes part of a strategic plan, but we do want to be sure that we're collaborating in order to get the best outcome for people. But yes, I do understand it would take a statutory language change. Can we do it together? That's the question.
I mean, we certainly would be able to, you know, if we have the clearance to do it. Since we are allowed to accept people who provide services in Maine to do it, that's not the barrier. I think the barrier is, you know, trying to get that through. And I think.
Well, when we created the CPHDH, we were, and that was 12 years ago, we were forced, if you will, to to add the statutory language that eliminated the ability for us to practice independently. And so, you know, I do know it will take a statutory language change in order to do this, and I certainly hope that the members of this committee and the members of these groups, DentaQuest, NED, DHHS, would actually see the benefit of this. Certainly in Maine it has benefits, so let's see what we can do.
So I think one opportunity to sort of get some face time with legislators is on some periodic basis, we present to the Health and Human Services Oversight Committee the status of the program. That'd be a good time to sort of take the temperature, whether you have any legislative support on that topic.
That's very good. Thank you. Thank you very much. You know I love this program. Okay.
We appreciate all your support.
But I would like to see action and movement, and let's hope that we can work together and have that happen.
Lisa has a question.
Thank you,
Amanda.
Lisa, what's your question for us?
First, I want to thank you, Sarah. Everything you're doing, and you're doing a great job. Thank you for this service. I have a question about, and I'm speaking as a mother of a child with autism and complex medical conditions and as a consumer advocate. Just wondering, were there any providers who were, I don't know if they would even tell you this, but I'm just curious, uncomfortable serving this population, was not sure about, doing dental work on individuals with developmental disabilities or behavior challenges or autism. I don't know. I was just wondering about. My son does great at the dentist and loves to go to the dentist, but I have friends who have children, and it can be challenging. And I was just wondering if anyone's ever mentioned that.
Right. Thank you for bringing that up. I do want you to know that that's another area that we're taking very seriously. And we actually have meetings that are centered around dealing with the part of our population that does have special needs of many different types. We are involved with the Able New Hampshire Oral Health Task Force, and we've got a wonderful working relationship with the folks in that group where we're really trying to understand, what is it that dentists know? What do they not know? What do they feel comfortable doing? What are they uncomfortable about? Individuals from ABLE are providing information about what their needs are, and really trying to get the conversation going amongst all of us so that we can help to support our providers to do what they need to do to feel comfortable treating everyone that might come to them as a patient. And, it's going to take time, but we are taking this very seriously, and we're trying to develop, one thing is a library of information that's available for our providers. We're trying to determine what type of education and continuing education might they need. So there's a lot of work going on. because we do recognize that we need more providers in that space.
Great. I am very happy to hear that you guys are good people. Thank you.
Thank you.
Thank you, Sarah, for everything you've been doing. Thank you.
Trust me, we have a lot of meetings all week long. I know Tracy Gilman is on the call from Northeast Delta, their Director of Governmental Programs. We are talking almost on a daily basis, either in meetings or emails or phone calls. So I want you all to know that there's a lot of work going on continuously.
Thank you.
All right, thanks.
Hey, Lisa, if you're all set, can you put your hand down? Thank you.
Anything else for Dr. Finney before we move on? All right, thank you so much. Let's turn it over to Scott Beckwith for the DDU update.
Yes, good morning, everyone. So for the month of August ending, we received a total of 133 new applications in, both adult and children's applications. For the children, we ended the month with a total of 44 cases pending. 3 of those were over 90 days. With the adults, we ended up with a total of 109 cases pending, with 513 of those over 90 days. You'll see that the majority of the cases are currently awaiting the final stages, meaning they're all ready for the medical review team to be reviewed, and just waiting for them to pop into the queue to be worked on. I know it doesn't look like there has been much improvement, but there really has. If you look at the numbers in the past compared to where we're at, we are going in the right direction. I would say, especially with the children's cases, the contractor did an incredible job. We are 100% timely on those children decisions now. And with the adults making good grounds. In the last meeting, I had let you know that we were bringing on a second contractor, and that had hoped to start in the beginning of September. Unfortunately, our contracts unit really did a great job getting everything out and over to the proposed vendor. Unfortunately, it didn't give them enough time to get the information back to us for us to hit the August GNC meeting. So therefore, we had to put it off until September, and we're on schedule. Everything's completed and on the schedule for the September 25th GNC meeting, which will then allow us the second contractor to come on to assist the first contractor. So we should start seeing these numbers going down even more rapidly. Our current contractor has made great strides at this point. Even with the holiday weekend, they closed out 40 cases. The week before, they closed out 67. So they're on track for that, 70 to 80 cases per week closing out now that they're in full form. That's really all I have. Does anybody have any questions for me?
I don't have a question. I just have to make the comment, and I apologize for making it, but I represent an association and a group of people. There's a lot of concern and growing angst with the, people. We have applications from December. People need services. They need access to medical care. It comes at me all the time. And I assured them that I would share their concerns here. Just gonna voice again, I know that 209B states are states that retain Medicaid decision-making themselves, and I don't know how many there are, 8 or something like that. But presumably, because we retained the same level of decision-making, I don't know, 1972 or something, or eligibility criteria, I don't know why we don't consider relinquishing that. I just don't understand why we repeat the process of deeming eligibility, but I'm I'm passing along many, many voices to you, is what I feel like I'm doing today, so I appreciate your grace. And I wish I wasn't apologizing for it, but I am. Thank you for your updates.
Thank
I pass them along every single month, Scott. I should also say, Scott's team really is phenomenal, responding. They're very responsive. He gives us tools to inquire, to ensure that we don't have things outstanding. If we have things outstanding, we can influence other providers to get in medical documentation. We send communications to DDU and they get back to us. I mean, in very short form that same day. So thank you very much for that, Scott.
Thank you. And believe me, your concerns are not unheard. You know, we do take this seriously. It was just unfortunate that this new contractor, when they came on in January, it took them 7 months to really onboard. And so we were kind of stuck with that, but they are on track now, and really have picked up. So we're going to continue to see these numbers go down rapidly. I have weekly meetings with them. I sometimes meet with them 2 or 3 times a week, get status updates to try and move things through quicker. So your concerns are not gone unheard. We are working on it, and I promise you it will improve.
Thank you.
I just have a sort of a comment, because I think those of us who have been around the table for a minute know that moving cases to decision in the DDU has been a pain point for probably more than 20 years. And so it seems like each effort that gets made, it's just not enough to consistently ensure that decisions are being made timely. And so picking up on Kelly's comment, I'm just curious, when was the last time that the department did a cost-benefit analysis of retaining 209B status versus going 1634? Because I feel like there's a lot of effort now with 2 vendors to determine disability when we could just take SSI's word for it. And I know there's other policies where New Hampshire is elected to be more restrictive, but, I feel like it's probably good hygiene from time to time to make sense that they've done that cost benefit analysis and said, whatever the value was in the 70s, has outlived its utility.
So on the disability determination standpoint, we're doing some work on that internally to try to streamline some of that where we can, based on some feedback that we've gotten. In terms of the 209B, I think fundamentally it's states keeping control of their New Hampshire sort of the trust of the federal government, in terms of fulfilling their commitments and not imposing things on the state. We've had that same issue with Medicaid expansion in terms of the unwillingness to make a definitive long-term commitment beyond, they've made a longer-term commitment this last time, but I think it comes down to, really the control of the state budget around that issue. And we have not done a cost-benefit analysis. I'm not sure, it's for the first time thinking about what would that entail, to be able to figure out who would otherwise qualify that didn't. But that may be something from a legislative standpoint in terms of raising that issue. Wouldn't be such a bad thing to do. I know it's probably going to be, states are, if you follow different institutes like the Urban Institute and the Commonwealth Fund, I think they're all identifying that this upcoming budget year is going to be one that's more challenging. The state revenues are starting to decline to make a policy decision, but I think in terms of asking for the analysis to be done and funded to be done, it's not something I would discourage.
Looks like we have a question from Karen and then Cheryl. Karen?
Thank you. Scott, I just want to make sure I heard you correctly. I think you said during your presentation that the vendor is now 100% timely. Is that the new determinations? Did I mishear?
I didn't say that the vendor was 100% timely. No, I said that they're 100% onboarded now. They've got their medical review team. They've made much better timeliness decisions at this point.
Got it. Okay, thank you. And I would love to add my 2 cents about the 209B status. It does seem like, it may be duplicative for New Hampshire to be spending all the money with vendors and staff to, make decisions that the Social Security Administration has already made. So if there's an opportunity to study that, to get information, I think it could be really useful. Thanks.
I would concur with that also.
Cheryl?
I was going to say, I mean, just segueing to the point you just made, Karen, about a study on the 209B status. I believe, I can't remember which report it was, but either the Guidehouse report that was done a few years ago or the one done by Alvarez and I can't remember it with the last name now. But
Marcel.
Thank you. Marcel, that's it. One of those did include a review of whether we should remove the 209B status. I don't know, probably should look at that. I don't remember what it concluded, but it was done.
Thank you.
Yep.
Thank you, Scott.
Thank you.
All right, next on our list is community reentry and youth reentry, although I don't know who's you're, okay, so yeah, for the next like 5 items, or 6 items, it's all Henry. Take it away.
So just in terms of, I think people are aware that July 16th, we were awarded our 1115 waiver, which included the community reentry requirement. And that is basically for adults. And our plan is to begin January 1st with the Department of Corrections facilities and then roll out to the counties. Actually, Friday, we made a presentation to the county administrators on both this topic and the youth reentry. Basically, the focus of the adult reentry program is to provide a pre-release set of services, basically establish the community connections so that when someone has a transition to come out to outside the 4 walls, that their relationships are already established, and then the reason that they're successful is because, at least in terms of transitioning back to the community, is because their medical needs, whether it be mental health or SUD. The focus of the adult program is on the behavioral health needs, and we have some work to do with the provider community and the MCOs to build out that, but that will be in our next contract amendment in managed care organizations to create a special benefit program. The idea of this program is, coming into jail or corrections, if they have Medicaid, you have to suspend that status 45 days prior to release. There'll be a benefit package that's provided that focuses on the behavioral and substance use disorder case management. Then when those 45 days are over and they're ready to be released, is checking their eligibility. A lot of people who are leaving who don't have employment are likely to qualify for Medicaid to get them into a regular managed care product, if you will. And so we're looking to start their Department of Corrections. the youth reentry component is not a voluntary thing like the adult community reentry. The youth reentry program is required of any carceral setting, including like SY Similar Youth Center, where individuals 30 days prior to release will receive a package of benefits. And that package is a little bit broader in terms of during anything that's EPSDT, including dental screening, is available to the youth. And youth is defined as anyone under 21, except it goes up to 26 for former foster care. And so, and that thing again, somewhat similar is, the 30 days prior to release, there's an assessment process to make sure that their needs are being planned for, screenings are being done, et cetera. And then the other big benefit of both programs is that if they have prescription drug needs, that the Medicaid program can pick up a 30-day supply of those prescriptions upon release. I should have mentioned that with respect to the adult reentry. So case management is a longer window for these individuals. Again, our plan is to use the managed care platform where we have case managers that are nurses within the managed care companies to be able to provide that. And the difference between the youth and the adults is that extra level of case management exists for 30 days post-release. So implementing it in the counties is going to be a very different situation because the average length of stay, according to the counties, is 48 or 72, 48 hours. There's a lot of people that go through it very quickly. So obviously you can't provide 30 days prior to. If you can't provide it in that time frame, then you still pick up that obligation to provide it within the 30 days of release. And again, the process is, assessing them before they come in for eligibility, assessing them at the time for the pre-release, and then upon discharge. I think as I look at it, it makes a lot of sense for the children that are being released to, rather than give them 30 days of benefit as a separate benefit, if you will, is to just, they're going to be eligible at release, is to just put them into a regular program. There may be some people that aren't, and we'll need that piece. But the counties are, when you see one county, you've seen one county. Talked to them, the administrators on Friday, about setting up meetings to start to do some fact finding, if you will, to understand the different levels of service. Some already have a stable of programs to deal with reentry, but we've got work to do with the counties, we've got work to do with providers, we've got work to do with the MCOs. That's all going to happen between now and the end of the year. It's pretty exciting and a lot of work to accomplish. Take any questions?
Does this, for your targeted provider group, does this include single shingles as well as groups, as well as the MHC?
Yes.
Right.
So, some people may have an SMI, meaning a specific designation, right? Candidate for the mental health center, for sure, right? To get them established. Some may have just an MAT, a substance use disorder, just may need an MAT service. The idea is to largely probably use telemedicine to have that intake occur as a billable service on the part of the provider. And then when they leave, that they know who they're going to see, they know when they have an appointment, and so there's that continuity of care. The Council of State Government's done a lot of research over the last couple of years on the number one reason for recidivism, getting put back into behind four walls, is related to mental health needs not being met, or substance use disorders. So there's savings for the counties and for the state by having the federal government pick up costs that otherwise statutorily have not been allowed to be picked up, particularly around the discharge prescriptions. And then in terms of the counties and the correctional system, to have less recidivism, reduce the number of people that are incarcerated, and then for the society as a whole, people who successfully reintegrate can become productive members of society and have them start their life again in the community and be successful. So this is really some exciting stuff for us and for I think the state at large and everybody who can contribute to it. We're looking forward to tapping into it.
One thought when I asked my question is, there are also people with and they may or maybe those providers may or may not be Medicaid providers. So sort of just keeping our ear to the pavement on that, and maybe opportunities to engage providers. That just ensures maybe some longer term some success for people for clear continuity of treatment. You already addressed that, yeah.
So one of the things we hope to have happen is using the Department of Corrections as an example, that there are people who are doing case management behind the four walls, and maybe being able to share that information. We'll need use agreements to be able to do that on an individual basis. But the idea is to pick up what we can learn about them. When you think about the youth reentry side, we're also concerned that immunizations and other important things that may have already been done, that we don't spend money doing things that have already been done, and also making sure that if they're not done, to get them coordinated to be done. But I think we'll be probably, we have a targeted benefit in the community reentry basis for adults. I think we focused on what we saw as the major issues identified by the Council of State Governments. Some states are doing a much broader reentry program. But we think we can focus on the key issue and get that going quicker maybe than any other state in the country in terms of actually having it a live instance of it. And some of the learnings that we've been gathering over the last 2 years have helped accelerate our youth reentry. I think CMS's expectations around youth reentry is that states minimally by January 1st will have an implementation plan and a state plan amendment in place. They understand that since this guidance came out in the end of July, that having something stood up by January 1st is probably pretty unlikely, though we still think we could maybe do that. We are going to do that for Sununu Youth Center and Department of Corrections, and working with the counties. It'll take a little bit of time to assess their readiness and so forth.
Right.
I just want to thank you guys for all the work on this incredibly important project. As someone who spent 10 years as an indigent criminal defense attorney, this is going to be nothing short of life-changing for so many vulnerable people in the state. So thank you so much for making this happen so quickly and effectively.
Thank you, Brooke. I think in terms of things that we've had to tackle, like getting people to see the benefits of mental health and substance use, the range of benefits that are available, dental, and this, I think those are 3 really big positive changes that will have life-changing things for individuals. The next topic is the MCO 3.0 implementation. We went live on September 1st with the new contract. Again, I think we've done some presentations before, but one of the key elements that we're standing up out of the ground, the benefit of people is to have real, authentic primary care relationships, and that entails not just on a piece of paper assigning someone to a plan, but actually making sure that they get an appointment, making sure that we'll be monitoring to look for wellness visits and the like. Also, a key component of it is delivering preventative services and paying for certain services that have historically had no compensation for providers in terms of care coordination, HRAs, medication reviews. And we've published a guidance document on this for the provider community. I think we could probably, it's up on our website, we could probably provide a link in the minutes to people who would like to review that. We're already working on our amendment 2, which is to go into effect for January 1. So not a lot I can say about that today other than we're go from one to the next one pretty quickly. We don't have anything to really lay out today for the opera spending plan. We did provide the link to the site if you want to look at reports we've made to CMS and what's going on there. I see we have a duplication.
Yeah, I just saw that.
So on to the waivers. I don't think there's anything I would really speak to other than the other components of the 1115 waiver. And we had made a request to renew the substance use disorder and the SMI, SED inpatient components. Those were approved. I think Sarah wants to weigh in on the dental component there, which was the ability to provide dentures. We talked about the community reentry already. We had also, as part of the system of care, made a request to include presumptive eligibility for the HCBS space. We weren't able to include that in this version, although we submitted an amendment to get that. And we're making some progress working with CMS on that. I would expect maybe sometime in 2025 we'll secure that at this point. So Sarah, I don't know if you wanted to weigh in there.
Yes, I think, Kristen, do you have my slide deck to put up?
I do. Just give me a second.
If not, can I share?
Yeah, you can.
All right.
If
that's probably faster. Hang on. Okay. Can you all see my slide deck?
Yes.
Okay, terrific. So this is our yearly report to this group on the denture portion of the 1115 waiver. I'm just going to go through, brief overview. We've talked about this a lot. The benefit was launched on April 1st of 2023 when we were working with CMS to decide the best way to make the dentures available to specific groups within our members. It worked out that for the nursing facilities, adding this on to the 1115 waiver was the way that we could get this in action for April 1st. It was the fastest way to get there. So it is very unusual, but here we are, and it seems to be working. This benefit is for individuals who are 21 and older and residing in nursing facilities. The benefit, as you all know, is managed by Northeast Delta Dental with DentaQuest, actually providing the services. So for significant actions, April of 23, the plan was implemented. In June of 2023, an extension was granted, which brought us up to June 30th of this year to have the dentures in this waiver. And then this June, we did receive a 5-year extension of the waiver, which includes that denture component for the entire 5 years. Their accomplishments are things that I talked about earlier today. We continue to see increased numbers of providers and locations where services are being rendered. We have a robust schedule of mobile services, which is also helping to increase that network. Our claims continue to rise month over month, as do our unique members served. As I said earlier, in the entire program, we're reaching close to 16,000 unique members served. We continue to collaborate with a number of oral health stakeholders, and this is to strengthen the utilization of the services and also to help develop the network. And that includes nursing facilities. It's another area where we have a specific dedicated meeting time on a regular basis to make sure that we are serving those members. At this time, there's approximately 100 nursing facilities in New Hampshire Medicaid that are serving approximately 3,500 members per month. The nursing facility staff do evaluate the members as they come into the residence, and they are assessed on a regular basis after that and are referred for dental services where required. What I will mention is that having dentures and partials and repairs to those is not, one-off appointments. So there are many appointments involved throughout the process, and the claims for this are not submitted until the services are complete. And on top of that, dentists do have up to a year to file claims. So we do find that there is a little bit of a lag at times with our claims coming in. Since in the year, and this is important, I know that we had that initial 3 months of April to June, but right now we are evaluating the last year. So July 1st of 23 to June 30th of 24 is the time period that's currently being evaluated. There is a survey that goes out to the nursing facilities for those members who have had denture services, and the state works with PHPG to do that analysis. In the time period of July 1st, 23 to June 30th, 24, 57 claims were submitted for removable dentures. 43 of those were for full dentures, and the remaining 12 claims were either for partial dentures or repairs. The current deliverables that we have are the evaluation that we are currently working on is due to CMS at the end of December, and that's followed up very shortly by our revised evaluation design for the following year. Will be due January 12th of 25. So we continue to monitor claims and review what the claims experience is. We look at survey materials to make sure that we're asking the right questions and hopefully getting the right answers, and then analyzing the results of that. And as I said, we're going through the process of revising the denture evaluation that is due to CMS next January. And I am happy to answer questions. Karen Rosenberg, I see you have your hand up.
Thank you. So my question is, and maybe I missed something, I thought my impression was that the prosthodontic or the denture coverage was also applicable for people who are not just in nursing homes, but who are on one of the 1915C waivers. Is that happening too?
That is happening, and I'm sorry that I wasn't more clear about that. That is still ongoing, but we do have to do this report to CMS on this waiver for the nursing facilities. So that's why I'm speaking specifically about this today.
Okay. Thank you.
That is the case. You got to do like 6 different pieces of approvals to get the dental.
We had a lot of spokes coming off the wheel of how we got this plan moving forward. You will also get a copy of the slide deck. It will be posted on our website as well. So if you have any questions in the future, you know where to find me, and I'm happy to answer any questions.
Thank you.
Thank you.
We have a question here in the room.
Sarah, I have some ideas I'd like to run by you specifically.
Okay.
For nursing.
Okay, you know where to find me, Joan. I'll wait for your call.
Great.
Thank you.
Has to do with the nursing assessments and how we can partner together to get good data for you.
All right, sounds good. Thank you very much.
So the last item on this list was the mobile crisis. There's a link there. We did submit the state plan amendment time to obtain the enhanced federal match on mobile crisis services that meet all the conditions elements of a full team, if you will.
We're still pending though, right?
Yeah.
Yeah, great.
We have no concern that we won't get there. Just
Thank you.
Thank you, Henry. Any questions before we move on? Seeing none. All right. I know we have these placeholders on the agenda for these 2 rules subcommittees, but I think both rules are in process, but I just want to make sure that the subcommittees have nothing either on the 805 or the 310 that they want to share.
This is Kara. On the 805, I don't have any additional updates.
Thank you.
This is Cheryl. On the 310, my understanding is that the rule header has gone through JLCAR and has gotten conditionally approved. So I don't think there's anything more for us to do on that one.
Can we take it off of the agenda going forward?
I think so. I mean, I'm, that's what I'm not sure what else we would do because it's already been approved. So.
Was there a comment?
This is Brian Clark from the department. I'm just concurring with what Cheryl said that it's been approved by JLCAR.
Great.
So we can remove it.
Yeah.
Okay. Great. I think we weren't sure about.
All right. Looks like there's 4 rules in various states of progress. Do we need to light on any of those or? All right. Seeing no comments in the room or on screen, we can move right along. Looks like we have a bunch of rules on the consent agenda. Remind me, Henry, we take a motion?
if there's any of these that you'd like to vote on. So maybe.
Are there any of these rules on the consent agenda that folks want to create a subcommittee on? Going once? Going twice? No subcommittees.
Just for those, I know we've done some PR on public relations work on getting out the roadmap. And I know Marissa Hen was here, the commissioner, a couple of months ago, 2 months ago now, to talk about it, but we've actually published the report, and this is all like for your convenience if you haven't had a chance to look at it.
Thank you. I'd like to just make one mildly self-serving remark about the roadmap. Chris Santinello presented on the roadmap at the long-term care conference a couple of weeks ago. And despite the fact that the want of a guardian is in the top 3 barriers to discharge for hospitals, and, you know, we've been in sort of a crisis point with guardianship, there's absolutely no mention of guardianship in the roadmap, and that was really discouraging to see. So.
And we are working with on special Medicaid representative, which is a limited form of guardianship, but with the nursing facilities. It's been in place since 2017, that law. I actually worked on it before I came to the department. That I think is something that I think when applications get hung up for a while because of financial information not being able to be had, that is something that we're actively working to improve the ability to use that.
Other comments? Questions? All right, and then we did create a new area on the agenda for parking lot items, and right now you'll just see that legislative updates are in the parking lot for now because it's September and there's not a lot to update. You know, we do sort of expect that as LSRs start getting filed, that, you know, we'll sort of resume those updates at a regular cadence, but right now there just really isn't anything, and the updates that have been provided most recently have been, you know, governor signed this, or this took effect without governor's signature, which is all information that we could look up on our own. So stay tuned for, I don't know, sometime in the next couple of months, so that'll come out of the regular agenda.
Karen's hands up.
Yep. Hi, Karen.
Hi, thanks. I mean, the parking place reminded me that it would be really helpful to, if the department could share, when it's shareable, the information about the budget request for Medicaid, because maybe there are items that we would be able to help support to make sure that our constituents are able to get the services they need. So whatever information can be shared, I think would be helpful.
Yeah, I think in the past we've provided a link when it's publicly available. We can maybe put that on there as a parking lot item so that you're aware of that and we can talk about it. At this point, we can't.
No, I'm aware that you can't talk about it, but I'm thinking that when it is public, when there might be an opportunity to, you know, ask questions, and maybe there's, you know, we're all interested in making sure that Medicaid gets what it needs so that our clients get what they need. So if there's opportunities for that, it would be helpful to have the information.
So I think we'll put that in the parking lot so we don't forget about it. Thank you for that suggestion.
Thanks.
All right. The last item on here is just about public notices.
Yeah, so just since we don't put things in the newspaper anymore, we publish them online. It's our intent to leave this particular thing here, so it's just a constant reminder if you want to see what's going on. This is the place to do it.
Excellent. It's nice you don't have to do it in the paper anymore, since
People don't buy the paper.
yeah, exactly. And if you are reading online, you're not zooming right to public notices. So that's nice. Welcome to modernity. Okay, I think we have reached the end of our agenda. Are there any other last questions or comments? Hearing none, I'll entertain a motion.
So moved.
To adjourn the meeting.
Joan, okay, Joan made the motion to adjourn. Kelly seconded. All in favor?
Aye.
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 Aye. Thank you, everybody.
Oh,
See you in a month.
Michelle has a hand up.
Michelle, did you have a hand up?
No, I was just saying aye.
Oh.
Thank you.
Have a great day, everybody.
Bye.
So,
We ended early again. Woo! Gold star.
so the membership committee, you're chairing that?
Apparently I am.
Okay. So,